Okay, hello everyone, and a very warm welcome to the final session of this team FRCR 2B sessions for the March exams. And there could not have been a more befitting ending than having Dr. Wasif doing our final session. So please, Dr. Wasif, without wasting any time, the screen is yours. Thank you.
Hi guys, so welcome everyone to this live session. We're going to do something different this time. We're going to start off by talking a little bit about the tips and tricks of the exam. Actually, during the past couple of weeks or so, I've been receiving a lot of queries from you guys regarding, just regular doubts of the exam. And I realized that, it's worthwhile to just spending 5 to 10 minutes speaking about those things rather than to individually answer those queries. So in the beginning, I would like to start talking about the answer structure itself. So all of us have knowledge, and we want to be able to put together our knowledge in a way that is, just hitting the marks as far as the exam is concerned. So generally speaking, what I've seen is in the books, and even as far as some of the older examiners are concerned, the structure pattern that they advise is not really the best. It's a bit outdated. So I have come up with my own sort of answer structure. So I just want to go through with it with you guys. So I have divided it into 8 key components, right? So first of all, the film comes up in the exam. So the first component would obviously be to introduce the film. So what do I mean by introduce the film? So when you look at the film, I want you guys to spend 1 second just looking at the periphery of the film, not in the center, not where the findings are, looking at the periphery of the film. So a lot of the times you will have, information regarding the phase of the exam, the MRI sequence, the age of the patient. All of these things cannot be actually taken out of the DICOM, data. And the examiners these days are showing live cases. They're showing through the Osiris platform, right? So it's not possible for them to filter out the data completely. So these things can give you an important clue towards the diagnosis. So just 1 second, just look at the periphery, come back to the center, and start describing the exam. So you want to take your time, take 3 to 4 seconds, and just describe what exam it is. So this is a frontal chest, for example, right? You want to say something like, this is a frontal chest X-ray of an adult patient. So you want to take that time, not because it takes that much time to describe the case, but because you, in fact, in the backside of your brain, you're thinking about the diagnosis, right? So you're looking at the findings, and what happens is, as you're introducing the film, within 4 seconds, you actually reach a diagnosis. Okay, this is what happens in the exam, right? I'm not talking about a differential, you actually reach a diagnosis. So it might be a differential case, right? It might be a solitary lytic bony lesion, but you actually, in fact, in your mind, you're already thinking about metastasis. You're not thinking about the other things. So reach a diagnosis first and foremost as you introduce the film. And the same technique can be applied for CT and MRI as well. You're slowly scrolling, you're describing, these are axial CT sections of an abdomen, soft tissue window, the scan is in venous phase. You're just scrolling, you're looking at multiple findings here and there. You gravitate towards a single finding which you think is most important, and you formulate that diagnosis. So this step, I think, is very important, and I feel most of the people just skip through the step. They just don't bother introducing the film correctly. Next, go to the striking finding. So the examiner doesn't really care that there's a renal cyst, or there are spondylodegenerative changes, or some chronic infarcts. So you don't want to start talking as soon as you see an abnormality. You just want to see through everything. You want to go to the striking abnormality. Okay. Next, what you want to do is you want to describe, once you have described the striking abnormality, just describe the associated features with it. So you already have the diagnosis in mind. You know the associated features seen with the diagnosis. So just automatically associated findings should come to your mind. And this is very important. Okay. Now that you have gone towards the path of your diagnosis, you need to start thinking about the differential diagnosis. And in your mind, you're thinking, okay, if this was there, then this would not have been like a metastasis, this would have been a benign lesion. So you have to talk about the pertinent negatives. Okay. Also, going with the same example of the lytic bony lesion, right? So you need to check the periphery of the image to see, if part of the lung is included. So just say there are no lung lesions in the visualized section of the left lung. Okay, or you need to say, in the visualized section of the abdomen, I cannot see any renal clips, any thyroid clips. So any pertinent negatives based on the differential diagnosis. Okay, once you have done that, what do you do next? So the next step, some of you might find it a little controversial, is going back to the clinical history, because in our books, most of the examiners, what they say bring up the clinical history as soon as you start the case, because you tend to forget it. But in my experience, the examiner does not give you the clinical history. The examiner these days, they just throw the case to you and they say, tell me about this case. What do you think about this case? Okay. So as you're describing these things, you get excited and you want to jump to the diagnosis. You want to close the case. So my advice would be to always, after the pertinent negatives, bring up the clinical history. Say this is a lytic bony lesion. So this person is looking like an old male patient. And the examiner himself or herself, they will give you the age of the patient at that point, and then you say, if this patient has come up with symptoms of infection, or just has some constitutional symptoms of weight loss, so stuff like that, you bring up the clinical history. Only after that you go to your diagnosis. Okay, once you have mentioned your diagnosis, now this is again a very important component that most people ignore. Look in the eyes of the examiner. Okay, the examiner with his or her eyes will tell you if you're on the correct track or you're going off track. Okay, so after the diagnosis, most people like to jump to the concluding part and close the case, but no. So for example, the examiner might look at you and go like, that means you're on the right track, you have the diagnosis. If the examiner goes a little bit like, so you need to go back and revisit your differential list or the main diagnosis, or bringing some additional information. So facial expressions are important clues. Examiners are instructed to be cold face, give no poker face, rather give no hint of whether you might be going on the right or the wrong track. But they are humans after all, and they are bound to like give you non-verbal clues. So finally, this is the optional bit. Most examiners, if you have done the upper bits properly, right, they know you have already considered the differential list. They know that you have described the striking findings especially if you use buzzwords. So they know that everything that you need to know about this case. So they don't waste time with differential diagnosis and asking you the manager. Most of the time, the manager is to refer the patient back to the physician, except for urgent cases, it's not that important. So you can close off the case at the 7th point over here. So again, I think introducing the film is underrated. Take your time introducing the film. Sometimes, even after you introduce the film, you don't have a diagnosis. What do? Take 2 or 3 more seconds, just pause, just scroll, be silent. Introducing the film is overrated. On the same hand, awkward silence is overrated. You want to be silent rather than to be wrong. So just take your time, get to the diagnosis before you start describing any of the findings. Okay. So these are some of the bonus components that I could think of. So you need to really structure when you talk. You don't want to blabber. You want to talk in a methodical way. So some of the people during my preparation, they advise, that you don't really have to prepare for the long cases section of the exam, because if you just practice Viva and if you see enough cases in Viva, you'll be able to go through the long cases very easily. I think preparation for the long cases actually gives you the background, the structure sentences that you use in your answers in long cases. You can use the same sentences. Solitary, well-defined lytic lesion, okay, is seen here and here. You don't mention about the size, you don't mention about this. So exactly the same thing. And then the conversation bit of the Viva exam starts really, once you have finished the pertinent positives, pertinent negatives, interpretation. And after that, when you bring in the clinical history, that is where the Viva component starts. So spend some time on, developing clear description patterns. And just looking at you guys give Vivas during the past few weeks, I've seen that the problem is not that you don't know the diagnosis, you don't know the description. The problem is you guys just keep talking a lot, after even the diagnosis is reached, and you say things which basically, you dig your own grave by saying excessive things. You use some terminology wrong here and there. So you want to just Focus on clear sentences and don't say unnecessary stuff. All right. The examiner itself needs to be respected. He's not your friend. He's not your colleague. But then he's not a villain. You don't need to fear him, okay, him or her, obviously. So you need to try and develop a friendly attitude. It will help break the nervousness, the tension that you have built in yourself. But also you don't need, you can't be like, oh no, yaar, what are you saying? This can't be. So you need to have that respectful boundary between him, but you also don't need to fear him. On the same note, you have to be confident in your diagnosis. So if the examiner asks you, could this be something else? So you are completely confident. Okay, so you reply, this is an Aunt Minnie. I'm sure about my diagnosis here, and the clinical presentation and everything fits perfectly well. I usually in my clinical practice, I wouldn't advise anything more to be done for this patient. However, if there's clinical discordance, if the tumor markers are elevated, then the patient will probably need further evaluation by an MRI to rule out a malignancy. So something of that nature. You need to show confidence in your diagnosis, but then you also need to appreciate that the examiner is trying to get some other information out of you, and give him that. So let's get to the FAQs part. The chat is open as far as I know. Dr. Sabha, is the chat open?
Yes, it's open.
So if anybody has any FAQs, any questions regarding the exam, you can type in the chat box. The common questions that I've been getting is regarding the types of cases in FRCR. So basically, they can be broadly divided into two things. First is spotters. You'll just get a spotter. And in fact, somebody in the last Viva, I didn't have time to get back to that question, but in the last Viva, a question was asked if book cases are shown in Viva. Absolutely. So spotter cases, in fact, I would think that 50 to 60% of the cases in the Viva would be spotters. Okay, they would be as clear as this. So you just have to have a script in your mind. You have to go through it. The next bulk of the cases will be differential. So you won't have a diagnosis necessarily immediately, but then they fit very cleanly into a differential subheading. So multiple cavitating lung lesions, something like that, bilateral symmetric T2 hyperintensities. So you need to have a differential for that, and you need to bring up clinical details in a way that you can give a final diagnosis. Also, when you so yeah, there are two main cases. So we have a question. I'll just get to the question. So the question is, can we scroll the CT a few times until we reach a diagnosis? I think 2 is the limit. So you go up and down, and that's it. You need to start talking. Okay. Another thing that I want to tell you guys is, sorry. So let's just get back here. So what content of the cases? Okay. So we know what sort of cases we'll get for rapid reporting. Okay. They'll have like a clean single abnormality, which will be very evident. I think even in the Viva, the cases will be very similar. You'll have a single abnormality. Okay. You won't have unnecessary images in the stack of CT cases. So you won't have to scroll unnecessarily. As soon as you start scrolling, you'll see the abnormality. And I have to give credit to the examiners, because I feel they go a long way in removing, incidental findings. So there are absolutely no distractions when you look at the cases in your exam. There'll be one solitary abnormality, and you just have to speak about it. In case there's like an incidental finding here and there, or you're over reading into something, the examiner will promptly tell you, don't think about that. We are not talking about that right now. So don't worry about being able to find the abnormality. I think it will be the easiest thing to do. In fact, reaching a diagnosis will also be the easy thing. Just dealing with the examiner and stopping yourself from speaking unnecessary things. That is the tricky bit. So two main categories: spotters, differential diagnosis with a clean subheading, and absolutely don't worry about will you be able to see the abnormality or not. So this technical issues question is also gets repeated a lot. Like I said, the abnormality will be very clear. It will be very simple. You won't have to scroll a lot to reach the abnormality. Scrolling is swift. The screens are good. It will be just like your reporting workstation. You won't feel like there is like any lag or anything. Okay. So what do you do when you hit a brick wall? Despite following the formula, despite following the structure and preparation and everything, you have hit a brick wall. You don't know what to do. So when I would hit a brick wall, I would go back to three main quotes. Okay, the first quote is actually from one of the external examiners. This was way back in the day when the Zoom thing had just started, and I think many of you didn't even have Zoom installed on your devices. So if the candidate would have any difficulty in locating the abnormality or just starting to speak, the examiner would himself tell that maybe this is not projecting very well on your screen, right? Out of the nicety. So this became the mantra for a lot of us. Every time we would have like any difficulty at looking at the case, we would say, it's not projecting very well. I'm not sure if there's a pneumothorax or not, And eventually one of the examiners, he said this: I wouldn't show you a case that wouldn't project well, because I know I'm taking this on the internet and you don't have like high definition screen. So this is a mantra that the FRCR examiners live by. They are not going to show you cases which have subtle abnormalities hidden here and there. They are going to show you direct cases, clear cases. Now you might not be able to see it because of some other reason. Okay, one of those reasons could be this: eyes can't see what your brain doesn't know. This was said very often by Dr. Khan. To be honest, I had heard this quote even before that. But basically, what we don't know, we can't see. But I feel by the time we are, giving the Viva, we have done enough preparation. We know almost everything. So almost everything. Okay, there were like one or two cases in the exam which I was still seeing for the first time. So this is usually not the case. So the third quote is this. This is essentially my code. So I would say this to myself, like if I can't find an abnormality, so I just need to take a deep breath and refocus. We are not trying to catch a train. This is not a race. We are not. There's no need to hurry. So I can't see any abnormality. Take a deep breath. Start looking at the film again. It will be something which will be pretty obvious in the end. Like last time we had the case of cleidocranial dysplasia where bilateral clavicles were absent, and sometimes you have the sacrum which is absent. So it will be very obvious. You just need to go through your review areas to reach the abnormality. So eventually you can smash the brick wall. So let me just go through the questions. Okay, yeah, one more thing that I need to go through before I get to the chat. Some of you have been asking about the viewing system itself in the exam. So there's a very good RCR demo site. I think I'll need to stop share.
The sharing is stopped.
Okay, so I need to start again. So let me just share screen again. Yeah, so this is the site. You can just Google RCR demo practice site. So essentially, you can just look at how the system is over there for the long cases. So you have a menu option over here. You can't scroll with scrolling the mouse. You need to select scroll and scroll. And it's worthwhile to just practice using keyboard shortcuts. Like for example, Z is for zoom. Okay, S is for scroll, P is for pan, and W is for windowing. And there are also shortcuts for bone window. No, this is for brain window. So O is for bone window. And each time you want to start scrolling again, you need to hit S again. And suppose if you have made a mess and windowing and everything, you can just press E to reset. Again, this is available here, but go log into the site, spend some time familiarizing with all the shortcuts. Okay, I think one of the rapid reporting sites also has a similar practice system. I know, I think it was, I'm not sure, I forgot the name, but yeah, just it's worthwhile practicing this. Okay, So let's get to
And the same
the
system
question.
in Viva as well, Dr. Wasif?
No, the Viva will be Osirix.
So the scrolling there would be with the mouse wheel?
Yeah, like how it is with I'm using Osirix as well. So you can use the mouse scroll wheel, which is quite comfortable. So is the screen sharing? Are you seeing the PowerPoint
Yes.
presentation?
Yes.
Okay, so let's. So Dr. Sabhat, you have gone through the chat, right? Are there like any important ones that I need to get to first?
One thing which I asked you regarding the Viva, so there is no, when we are scrolling on the MS Teams, there is no bar at the top. It's basically just like we are scrolling on our Zoom sessions. Is that the way it is? Because in Dr. Khan's at times Viva sessions, we see the candidate going to the top. There is a bar which they drag along. It's not like that, is it?
To be honest, I did not pay attention to the bar because the scrolling was so comfortable with the mouse wheel, but it was Osirix. So
Okay.
whatever you have on Osirix, you'll have it over there.
Okay.
Okay. So I think I answered this question, how to handle a situation when you're stuck, right? So brick wall, go back to the beginning, start from the beginning. So Dr. Sabahat, your question was, do you mean in Viva or do you mean in?
No, I meant in both, but I think you answered both of them.
All right.
There is another question. I think you skipped one. What if when we get a CT scan, can we scroll it a few times if we don't get diagnosis in the first go?
Right. So you can scroll it once as you're describing the CT, right? And you can scroll it back up, right? I'm just scrolling through the images first. And you can take my word, by scrolling it just once, you will get the diagnosis. And by scrolling it back up, 100% sure you'll see the main abnormality, you'll have a diagnosis, you'll have something to speak about. Okay. And if you have multiple findings, like I said, the examiner will push you towards the main finding.
Right. There are a number of questions. I'll let you be the judge to answer it right now or in the end, or if it's been covered.
So there's a question from Dr. Mohammed Yusuf. Could this be something else? That means they want to push you to other diagnosis. So if I stick to my diagnosis, maybe. So this is tricky because, it depends on your confidence really. For Aunt Minis, if they ask you, could this be something else? They might be checking your confidence. That's it. So I mean, if you have done the work, if you've seen enough Aunt Minis, you can be super confident that this is an Aunt Mini. I mean, it still could be something else, but given that this patient's clinical history is aligning well with what I would expect to see with this pathology, so I'm quite confident this is the diagnosis. However, if something is discordant, then I would go ahead and scan the patient with some other cross-sectional imaging. Do soft tissue sarcomas have to be referred to sarcoma MDT or for, so sarcoma MDT would be the correct answer. So range of pathology in RR, basically acute cases, mostly trauma cases. You still get lymphadenopathy, particularly mediastinal lymphadenopathy, maybe one or two anterior mediastinal masses, but mostly trauma. Do we have to measure the size in long cases? You don't have to measure the size anytime, not in long cases, not in Viva. You don't even have the option of measuring the size, like I said, in the practice system. Okay, Dr. Sabahat. So MS Teams, again, that will be Osirix. It will be just shared using MS Teams. As lateral radiographs are not common, should we ask for lateral views in chest? No, never ask for lateral chest X-ray. There's limited role of lateral chest X-ray. In case the examiner has the lateral chest X-ray, you'll be in more trouble actually trying to describe the pathology on lateral chest X-rays. Other musculoskeletal system, definitely ask for additional views. Even for skull X-rays, ask for additional views. I'm not sure. What are the usual diseases that should be discussed in non-oncology MDT? Everything else which is not oncology, I guess. What if you diagnose a case? Yeah, revised radiology and rad exams, they both have the similar practice scrolling systems. So MDTs, you can spend time, specific MDTs, this and that MDT, but like I said, if you do the case well, they don't ask you the management, they just show you the next case. So Viva wants to know what to focus in the last week. I would say go back to Radiopedia playlist, go back to your books. System wise, no case is too simple. Every case has to be revised, and staging wise, you can read staging for lung cancer, cervical cancer, lymphoma, and sarcoidosis. So you need to know the staging for these 4 things. Sarcoma MDT for bone tumors or just sarcoma? Bone tumor, sarcoma, I think for both. You can just, because most malignant bone tumors turn out to be sarcomas. So you can refer those patients to sarcoma MDT, or better yet, you can refer them to sarcoma centers. They have sarcoma centers. All right, so we are done with the questions in the comment. Finally, with this slide, I just wanted to say best of luck to everyone. I'm sure, all of you will pass, most of you will pass in the first attempt itself. And, once you pass, you're going to thank your parents, your teachers, you're going to thank your spouses, your kids, and probably even the maid for taking care of your spouses and kids. But remember, some random people on the internet helped you along the way in your journey to passing your exams. So you have a responsibility to help those people behind you. So best of luck, inshallah. Now we shall move on to the Viva component. Just give me a second. Sorry, it's not sharing well.
This is fine. Okay, take your time.
So this, okay, has not happened before. Okay, yeah, got it. All right. Sorry about that. So, Kavya, is it the first participant?
Yes. Yes.
All right.
It's me.
So, can you request
Yes,
remote
I
control
will
from me?
request control. Okay, I have sent you the request.
All right. So, yeah, tell me what do you think about this case?
Okay, so I'll just go through the images.
Okay, yeah, sorry. Just let the mouse go. Let me just reset.
Shall I just scroll using the mouse wheel, or do you want me to use the right arrow?
Either way, you can either use the bar, the mouse wheel,
Okay.
the thing, but I forgot right now how to reset. Yeah. All right, so you can take back the remote control.
Okay, and yes, I'm trying to. Okay, I'm going through this data set craniocaudally, and it seems to be a bit stuck. Okay. It's a bit slow. I'm not sure if there is something wrong with my end.
You want to scroll using the arrow keys?
These ones? If you can see.
The right and left arrow keys on your keyboard.
Okay, yeah, I think I'll use that. Just give me a second. Okay. Yeah, I think it's better, working a little better. Okay, so I'll just go through this data set. This appears to be contrast enhanced CT images of the abdomen of a male patient. And I don't have any clinical details. I can see there is a fat containing mass that is located around the right iliac region with a peripheral hyperaccumulating rim. And I can also see there is some amount of fat stranding, perimesenteric fat stranding along the lesion. I don't see any obvious large fluid collections. I don't see any intraperitoneal free air. And I'm just trying, there is no bowel dilatation. No organs appear grossly normal. So this appears to be a fat containing lesion with a hyperaccumulating rim. My first differential for such a condition would be epiploic appendicitis. I'm trying to see if I can see a central dot. And yes, there is a hypertensive central dot within it, which could be the torsed vessel. So I would like to know more about the history of the patient, if he's presenting with a right-sided pain.
Yeah, just no acute onset right iliac fossa pain.
Okay, I'd also like to see this, just see the appendix to see if there's no any concurrent appendicitis, but I don't think I can see a dilated appendix in here. So in summary, this appears to be a case of epiploic appendicitis. I would inform the physicians of my findings, and this can be managed.
Do you have a differential for this?
Another differential could be an omental infarct, but the central dot.
How would a omental infarct normally present? I mean, radiologically.
It will be much more ill-defined usually, and I think the site of an omental infarct is more along the left side, if I'm remembering correctly. And
is there any size criteria to discriminate the two?
Not that I'm aware of. No, I don't know.
Okay, so how are these cases usually managed?
This can be managed conservatively. They don't need any operative management. I'll just inform the referring physician of my findings.
All right, just give me 1 second. I'll load up your next case. Yeah, this is your next case.
Okay, so I am looking at the frontal chest X-ray of a skeletally mature patient. The most striking abnormality I can see is that the cardiac apex is situated on the right side. I'm trying to see the stomach bubble, but I am not completely able to appreciate the stomach bubble in this patient. So in the rest of the film, on the left side, I can see there is evidence of peribronchial thickening with some evidence of bronchiectasis along the left lower zone. And on the left side, the rest of the lung appears grossly normal. And on the right side, I can also see there is some nodular density with central lucency, which could be representative of bronchial thickening. I don't see any pneumothorax or any evidence of. There is some blunting of the left costophrenic angle with, I think, a nodular density that is abutting the left hemidiaphragm. And the rest of the lung appears grossly normal. So in summary, this appears to be a case with dextrocardia, bronchiectasis on the lower lobes, and possible nodular opacity along the left hemithorax. My first differential could be Cartagena syndrome. I would like to know more about the history of the patient, compare with any previous images to see the bronchiectasis progression.
That's fine.
Okay.
So just go through these images.
Okay.
Just 1 second, sorry. Yeah, I understand. Just give me 1 second.
Sure.
All right, now go through the images.
Okay, I'm not able to scroll.
Fine, I'll scroll for you.
Yeah. So I'm going through a few spot images from the ultrasound of the breast, and I can see that the right subareolar region appears to be slightly enlarged and yes, the right subareolar region appears to be slightly irregular. I can also see, okay, I think it's both the nipple and the subareolar region show a slight irregular enlargement with some speculated hypoechoic areas.
So this is a 12-year-old boy who presented with bilateral breast enlargement.
Okay, okay. So I can see that these enlargement appears to be almost a flame shape in nature. With the adjacent breast parenchyma shows some areas of some signs of edema. In a 12-year-old patient who is having a boy who is having this, I would be suspecting a gynecomastia. Usual causes of gynecomastia, which will include drugs, any cases of liver cirrhosis, or any tumors that is causing imbalance in the body's estrogen testosterone ratio. I would like to evaluate these causes in this boy, and also know more about the history.
Okay, that's fine. Just give me 1 second.
Mm-hmm.
So this is your next case.
Okay. So I'm looking at the frontal chest radiograph of a skeletally mature patient. I can see that there is a diffuse there is a space opacification that is predominantly noted along the central and the central perihilar regions. There is blunting along the right and the left cardiophrenic angles. I can also see there is a possible cavitatory focus, though I'm not along the left upper zone. I can appreciate
you can ignore that.
Okay. I'm trying to see the cardiophrenic contours, and they appear to be almost non-obliterated. The cardiac size appears to be mildly enlarged. This, in short, in summary, this appears to be a case of airspace opacification predominantly along the center as well as the upper and mid zones, with a slightly increased cardiac size. My differentials of this will include cardiogenic pulmonary edema or an ARDS. Sorry, I'll go first with ARDS first because I don't see any obvious effusion. Other causes of this can be any infections like bronchopneumonia or a PCP pneumonias. Malignancy can be an option too. I would like to know more about the history of the patient and how he presented with.
The patient presented with acute respiratory distress and he has fever.
Okay, so since the patient is having fever and some, I would go more on the lines of infection. And this pattern of central opacification, I would be thinking about more along the lines of a PCP pneumonia. I would like to know if the patient is immunocompromised.
Yes, the patient is immunocompromised. Can you go through this CT images?
Sure. So I am going through the CT images of the patient who has presented with respiratory distress and fever, and I can see that there is opacification and some ground glossing noted along the perihilar as well as the peribronchobascular, as well as a bit along the peripheral distribution as well. I can also see some fibrotic changes. I don't see any obvious pneumothorax. There is a mild pleural reaction on the left side. And there appears to be a mild tree invert-like pattern along the right middle lobe, which makes me suspicious of any endobronchial type of infective pathology. And there is architectural distortion as well.
So does the CT confirm your diagnosis, or are you thinking new things now?
This does not look like a typical picture of pneumocystis carinii pneumonia. I can see that the patient had some prior chronic pathology as well, because I can see some fibrotic changes. So this can be some kind of an acute on chronic infection. And
what is going against PJP in this case?
I'm sorry?
What is going against, what features are you seeing that is not supporting your diagnosis of PJP in this case? Anything that is lacking, or
I cannot see any nematocele. And there is a bit of fibrotic changes I can see over the left lung, and I can also see there is some infiltration on the pleura, on the fissure. This looks like a bit of a fluid infiltration, and a pleural effusion is uncommon in the case of a pneumocystis carinii. But still, I would first go with the diagnosis of a pneumocystis carinii infection.
All right.
Okay.
That's fine. Okay, so those were your cases.
Okay.
Yeah, so I think you did quite well.
Yeah.
So we'll just start the discussion. Just give me one second.
What was that case?
This was pneumocystic PJP.
Really? I mean, I don't see any pneumatoceles. It looks a little bit, it's not like a typical ground glassy appearance.
Yeah, there might have been some chronic infection, like you said, but
Okay.
overall it was PJP. So again, screen share. All right. So the first case, perfect. It might look like a case which is too simple for the 2B exam, but even diverticulitis came in the exam. So the differential for this, the first differential would be diverticulitis. The next consideration, in case the presenting history was given to you by the examiner was right iliac fossa pain, then you would speak about appendicitis. But if you're seeing just that, then appendicitis would not be in the differential. So here you have some thickening of the peritoneum, you have the central dot, you have this hyper-enhancing, or rather just thick wall surrounding this fat pathology. So these are classic features of epipleuic appendicitis. There's some fat stranding. Your pertinent negatives were on point. There's no pneumoperitoneum, there's no free air. And normally when you say there's no free air, also just mention that, however, I would confirm this on lung window images. So they love to hear that. Then next thing you want to say that there's no collection, there's no free fluid, there's no collection. Okay. So if this patient, you ask for the history, but if this patient presented just with right iliac fossa pain, then this the most likely diagnosis here would be that of epipleuic appendicitis. The differential for intraperitoneal fat containing necrotic lesions would be omental necrosis. However, omental infarct would be much larger. The size criteria is 4 centimeters. Okay. And it would be higher up. It would be along the colon rather than down here along the sigmoid. So along the sigmoid, the most common thing would be epipleuic appendicitis. Management is conservative, like I said. So the next case. So generally in the exam for cartogenous cases, they show you flipped image. Okay.
Yeah.
So this is how they would show you in the exam. But I decided to be nice. In retrospect, I think you are more than capable of diagnosing it even with a flipped image. So that's the importance of just looking at the image markup, right? So if the image was shown like this and you picked up the image marker and it was flipped, and then right away that there's something fishy going on. The description was on point. Dextrocardia. There's so let's just flip the image back up. You flip it. Yep. So there is dextrocardia, there is bronchiectatic changes with peribronchial thickening. Okay, and then again, pertinent negatives, no air, no fluid, no other lung lesions. The bony skeleton appears unremarkable. There's no mediastinal lymphadenopathy. Just 3-4 clean pertinent negatives. Okay. Right, and then you bring in the clinical history. The patient might also have sinusitis. In fact, this patient did have sinusitis. So that would be a good thing to say when you're bringing up the history. And the differential, I don't think you mentioned the differential for this.
I didn't. To be honest, I don't have any differentials for this condition. It's like
so just bronchiectasis, you would put in cystic fibrosis.
Okay.
But since there is dextrocardia, so it's more in keeping with cartogenous syndrome, right? But any bronchiectasis, you can put in cystic fibrosis. They're more likely to involve the upper lobes, and they'll have like a similar picture to this.
Okay.
So this was spot on. A lot of people will, wrongly interpret this appearance as inflammatory breast changes, but if you didn't have the history, you're probably going down that route.
I was actually going down that route.
Yeah, but the thing is, it wouldn't be involving bilaterally. So bilateral symmetrical changes, and this type is actually dendritic gynecomastia. You have like these finger-like projections going into the posterior breast. So once you have like bilateral changes, it's very hard to be inflammatory. And so next time, even if the examiner doesn't give you the history, just bring up, this since there's bilateral enlargement, I would, ask for the history of the patient, how he presented.
So what was the etiology of gynecomastia in this case?
No etiology actually. We referred him for workup or hormonal workup, but we don't know. He was a regular boy actually. He didn't take steroids or anything. So yeah, bilateral perihilar opacities in a batwing configuration. I don't think the pleural effusion is not significant, at least. You have mild cardiomegaly. So here again, you didn't bring up the clinical history before you went to the differential, right? Okay, you just directly jumped to ARDS. You went on about 3-4 things which were not the diagnosis in this case, and then you thought about I should ask the history. So that can save you some time in the exam. If before the diagnosis you bring in the history. Okay. So I think I'll need to zoom it in a little bit. So there are scattered lung cysts actually.
Okay, yes, there are.
Here and there, right? Yeah. These are lung cysts. Yeah.
I didn't see them the first time.
Yeah. So they are perihilar, ground. This is ground glassing. Okay, perihilar ground glassing is there. There are multiple scattered small lung cysts, and the fibrosis is in the lower zones. This, like you said, could be some chronic. Maybe a patient had old TB or something. But the acute symptoms, the cause behind it was PJP.
Okay.
And it's not going to be anything else with batwing appearance and history of immunocompromise. Just be confident with PJP. Don't get confused.
Okay.
Okay. So, Dr. Sabha, do we have the next candidate?
Thank you so much, Dr. Wasif.
You're welcome. You're welcome. Take care. Best of luck.
Yes, we do. Dr. Stuti, can you unmute yourself? Yes.
Hi, I'm here.
Hi, Dr. Stuti. Uh,
Hi, Dr. Wasif.
so if any one of you is comfortable with turning on their video, it would be nice, just to have some facial interaction. But otherwise, if you're in our PJs, I know we won't be comfortable. So this is your first case. Can you?
I'm provided with a frontal radiograph of the abdomen. I can see that there are multiple there are multiple radio-opaque densities, rounded densities seen bilaterally, predominantly overlying the renal shadows. I suggest these represent nephrocalcinosis. I'm looking at the rest of the abdominal scan. I can see that there is a radio-opaque density also seen in the pelvis, and along the left, adjacent to the left, on the left side of the L4 and L5 vertebral bodies.
Do you mean, can you point them out to me? I'll just give you the remote control.
Yeah. Yeah. Sorry,
so you
on the
need to
right
just
side,
click here. Yeah, okay, fine.
Yeah, yeah. So there are also some radio-opaque linear and oblong densities seen along the transverse process of the L4 and L5 vertebrae on the right side. So I
think you can. Yeah, tell me.
Some renal calculi, the ureteric calculi.
Actually,
so
you can ignore the linear opacities for now. Just comment on the rest of the findings.
Okay. So based on the bilateral renal the calcific densities, this is a case of bilateral nephrocalcinosis. I would like to inform the findings to the referring clinician and suggest correlation with any previous radiographs or ultrasound if available, and also rule out possibility of associated hyperparathyroidism. Although on this scan, I do not see any other features like Ragajosi spine to suggest that there is any secondary renal osteodystrophy. And yeah, I'll refer the patient to the urologist for further management.
So you skipped a couple of things from the components there. Did you use the clinical history in reaching your diagnosis?
No. So okay. I'd like to know what was the clinical history of the patient.
This patient presented with right loin pain.
Okay, so in view of the right loin pain, I suspect that there is a right distal ureteric calculus, which is possibly causing the pain in this case. In which case, I would like
to.
So
you said there is medullary nephrocalcinosis. Do you have a differential for this appearance?
Medullary sponge kidney could also give a similar appearance. And in view of the ureteric calculus that could be causing the pain, I would suggest for an urgent urology reference.
What is your other differential for medullary nephrocalcinosis? So you said hyperparathyroidism, you said medullary sponge kidney, anything else?
Some medications can cause nephrocalcinosis. Yeah, and acute tubular necrosis can also cause nephrocalcinosis.
So your next case, I'll just switch this to scroll 1 second. Okay, so now you can take.
Yeah, so I'm provided with MRI sequences of the leg, of the thigh, of the thigh and knee region of an adult patient. As I can see that the growth plate is fused. I'm scrolling from down upwards. I can see that there is the altered bone signal seen on these T2-ated STIR images involving the medial aspect of the patella and the lateral aspect of the tibial condyle, suggesting that this is a case of relocated displaced the patella dislocation, and there is joint effusion also seen at the side. I am looking at any evidence of fractures. I do not see any obvious fracture. However, I would like to correlate with T1 weighted images to see any obvious fracture lines. I can see that there is fluid signal seen in the joint effusion, likely due to hemorrhage. And I would like to correlate with the history of the patient.
The patient had a traumatic fall on the knee.
Okay. So in view of the history of trauma, there is likely hemorrhage at this site. However, in view of the classic appearance of opposite sides of the patella and the tibial condyle showing bone edema, I suspect this patient had a patella dislocation, which has been relocated. And I would inform the findings the referring clinician, suggest any correlation with any previous similar history or previous imaging.
What would be the source of hemorrhage in this case?
The source of hemorrhage. Okay.
Why would this patient, if the patient just has a simple dislocation relocation, why would there be hemorrhage?
True. So I would, in my routine practice, also look at the sagittal and coronal sequences to look for any associated ligamental or meniscal injuries.
So can you look at these images first?
Yeah. I'm looking at the sagittal T2 weighted images. Okay, this is a single. This is not a single.
This is a single. This one's.
Yeah. So
you need to click actually.
Yeah, I just read that. So I'm looking at the sagittal T2 weighted images without fat sat, and I can see that there is. I'm just going to scroll it one more time. I'm looking at the ACL and the PCL, and they appear to be normal. I do not see any altered signal.
Yeah, I agree. You know, the ligamentous structures are unremarkable. So I'm going to give you back the stir images. I just want you to scroll through them and give me your final thoughts.
So I see that there are a few intermittent signal loose bodies within the region of the effusion. I'm trying to see if I can see any source of them. I can see that the patella on the medial aspect appears to be damaged. Likely some bone fragments have displaced from the patella.
Can you show me which bone fragments? What do you mean by bone fragments?
Yeah. These ones here. So these could represent. Sorry. These could represent some loose bodies, or if, they could also be a case of synovial osteochondromatosis with osteoid matrix.
So you expect loose bodies to float on the effusion in that manner?
No, and they would not be floating there. I'm sorry, I'm not able to proceed further beyond this.
Fine, just take a look here. These are the T1 weighted images. Any final thoughts?
Yeah, so there is a linear signal with
Ignore. You mean this, right? Ignore this. What about the rest?
No. I mean, in the tibia, I can see that there is this linear area of reduced signal, suggesting that there is a fracture of the femoral, the fracture of the femoral condyle, the medial femoral condyle, and there is just lipohemarthrosis associated with the patellar dislocation.
So what were those loose bodies?
Those loose bodies were likely just I'm not able to comment. It could be just some no, I am not
What
able to
floats on
comment
top
on
of effusion?
that. Fat, fat droplets, but they would appear hyper intense.
Okay, so next case.
Okay. So I'm provided with an abdominal radiograph of a female patient who has so I would, I'm trying to go through the review areas because I don't see any obvious abnormality on the scan. So looking at the scan, the diaphragm appears normal. I do not see any free air under the diaphragm. There is to right. I'm looking at the ribs, which are visualized, they appear normal. The density of the spine has been entirely opaque. I don't know if that's intentional or.
Don't worry about the spine.
Okay. Patient has patient likely has breast implants. And I do not see any obvious signs of rupture. I would like to. I don't see any obvious fractures or any other obvious abnormality on the scan. I would like to correlate with the history of the patient.
This patient presented with acute tender abdomen. On examination, she had board-like rigidity of the abdomen.
Okay, so I do not see any abdominal gas shadows on the scan, except for the stomach bubble, which shows fluid level within. And in view of the history, I'm trying to look for any signs of perforation, which I do not see. There is no portal venous gas noted to suggest any ischemic bowel. And I do not see any obvious bloating of the abdomen to suggest ascites. I would like to suggest for an ultrasound or
so have you
CT
completely
scan.
ruled out pneumoperitoneum with this film? Is there something else that you would like to do? The patient is still on the
I would like to do an erect chest radiograph. Right. So on the erect chest radiograph, I can see that there is free air under the left dome of diaphragm and likely also under the right dome of diaphragm, which was not well appreciated on the previous radiograph. So in view of this, I would like to, I can now see retrospectively that there is the focus. So, however, it was better appreciated on the erect chest radiograph. I would like to urgently inform the findings to the referring the clinician and the surgeon on call and suggest a CT scan for looking for the cause of the operation. So I'm provided with post-contrast. I'm provided with post-contrast axial CT images. Just scrolling from craniocaudally. So I can see that there is free intraperitoneal air as well as free fluid seen in the anterior abdomen on the current images. And I'm just scrolling down to have a look at the complete scan before I can comment. Okay, so I was trying to look for any obvious other signs of sigmoid diverticulitis, which I do not see. In view of the quantity of free air and the location of the free air, I suspect the cause of the pneumoperitoneum to be a likely duodenal ulcer. The bowel appears normal. Otherwise, I do not see any signs of obstruction or ischemia. On this scan, I would like to inform the financially referring clinician and suggest for a gastroscopy and
the surgeon is not too
correction of-
convinced that it might be a peptic ulcer. So is there any way we can confirm this?
we could do an endoscopy to look at the site of duodenal.
I mean by radiology, because he doesn't want to waste time doing endoscopy when it could be like a diverticular perforation. So
we could give a rectal contrast to look for to opacify the sigmoid colon better and see if there are any diverticuli, because the sigmoid colon on the scan appears quite collapsed and we're not able to appreciate it well.
but why would we
I
give rectal
am not
enema when we're not
suspecting it.
suspecting? Yeah. So what would be the more appropriate thing to do for us to confirm?
A capsule and a CT capsule.
Yeah. So
endoscopy.
does this patient have oral contrast?
No, the patient doesn't have oral contrast, so we can give a soluble oral contrast and look at the site for leak.
Which contrast would you prefer?
We'll prefer the contrapack, like a radio opaque oral contrast.
Okay. So these are the images. Sorry.
Okay, so I can see that there is
does it confirm the your diagnosis?
1 second.
No, I don't think you can scroll that, just on this image.
Okay. So yes, on this scan, I can see that there is a focus of free air seen near the third segment of the duodenum and anterior to the right kidney along the liver. So there is likely a perforation from the side from the duodenum itself.
Okay.
There is
next case. That's fine. That's next case.
Okay. Provided with post-contrast CT images of the abdomen.
So if you say the introduction within a sentence before even schooling the images, you'll have an awkward time schooling the images. You know, you need to like prolong that. I'm provided with the post contrast, or contrast photovenous phase, axial section, and all those things as you're scrolling. So you don't have that silence.
Right. Okay. So I am provided with a photovenous phase of the post-contrast axial CT images of an adult patient. I can see that there is free fluid and significant momental fat stranding noted on the scan.
Is it just momental fat stranding?
Sorry?
Is it just mental fat stranding, or is there something more?
No, I'm just scrolling from I'm scrolling it upward now to look for any other associated findings or features. So I can see that there is subcutaneous fat stranding also noted in the region of the umbilicus, and I'm looking at the bowel and the mesentery. The bowel appears normally. There is omental caking seen throughout the scan. So in view of the omental caking, my I'd like to, of course, correlate to the history of the patient. And
Patient has fever, diffusely tender abdomen.
okay. So in view of the fever, I suspect infection to be the primary cause for this appearance. Momental caking is commonly seen with an abdominal cox. I'm trying to look for any other enlarged lymphadenopathy or look at the pelvic region to also rule out any other possible causes for the omental caking. This is a female patient. I'm trying to look at the site of the ovaries. I do not see any abnormal pelvic pathology here. Yeah, so I suspect this to be a case of abdominal cox with also some inflammatory changes along the umbilicus in the subcutaneous tissue. I would inform the findings to the referring clinician and suggest for an image-guided biopsy of the peritoneal thickening for culture sensitivity and evaluation for cox. And there are no abnormally enlarged nodes, however, seen on this scan. I would also like to correlate with a chest or a radiograph of the X-ray to look for any primary tuberculosis within the lungs as well. And if the patient has any previous radiographs or any previous imaging done, I would like to correlate with that as well. And put the patient under isolation and until further management.
All right, Dr. Sati. So that was your last case. I think we'll just start with this case because, it's just fresh in my mind. So I think I gave you one tip during your Viva itself that, as you're saying what study it is, just keep scrolling. Don't describe the study in a single slice. And what you're actually doing is you're actually looking for, the pathology. So over here, you can see that there is massive omental caking, which we eventually got to. There's also fluid. And these are the striking findings, right? So you need to go hunt for the associated features or the pertinent negatives. So in your mind, you're already thinking cox, you're thinking metastasis, you're thinking other things which can cause this like mesothelioma, right? So you need to say there are no pelvic masses, there's no abnormal bowel wall thickening anywhere, and there's no calcification. So these would put you in the realm of appreciating your differential diagnosis. And then you need to bring in the clinical history. So I would correlate with the patient's clinical history. Usually when you say this, the examiner will give the history on his own. In my experience, I didn't have to actually say if the patient presented in some way. So as soon as I said, I would correlate, the examiner wants to give you the history. So fever, abdominal pain, weight loss, these are all features of abdominal TB. I don't think they use the term cox anymore, especially in the UK. At least here we don't. So you'd be better off just calling it cox. And then the management was very good, but you said biopsy of the peritoneum. So biopsy of the omental mass would be the correct thing. So you make a mistake here and there, they might latch onto it. You don't want to give that opportunity. Okay. So rest of it was fine. So overall, I think you need to just work on your structure a little bit, how you bring in the clinical history when you bring in your diagnosis, rather than, just saying it right in the beginning. What's this now? Okay, so this was your first case. These are post-appendicectomy clips. Okay, so that's why I told you to ignore this.
Okay.
And your main findings are here in the kidney, which is rather than just renal calcinosis, it's better to say medullary nephrocalcinosis. Okay, plus a few distal right ureteric calculi. So depending if the patient has presented acutely, these could represent. And additionally, you can say, that there's no central lucency. Fibulae will have that central lucency. So most likely these are representative, especially given the appearance of the kidneys. These are representative of distal ureteric obstructive calculi. Okay. So that, and then you don't just stick with one diagnosis and close the case. I think the first time when you were speaking, you just spoke about parathyroidism, hyperparathyroidism, and then you just went into management and just close the case. So that would be a mistake in the exam. You need to go step by step: positives, pertinent negatives, clinical history, interact with the examiner a little bit, and then close the case, saying the most likely diagnosis over here is that of medullary nephrocalcinosis, and the differential for most likely diagnosis is medullary sponge kidney. The differential for medullary nephrocalcinosis includes renal hyperparathyroidism and why did I say renal? Just hyperparathyroidism and renal tubular acidosis. So having said that, do you know any associated conditions with medullary sponge kidney? This is an exam question. So associated conditions with medullary sponge kidney are Caroli's disease and Beckwith-Wiedemann syndrome. Okay, so just for everyone's satisfaction, this is the coronal CT images. So you have this calcinosis, which is limited to the medulla. There's renal dilatation of the collecting system, and there are distal ureteric calculi, and these are post-appendicectomy clips. So this is a tough question, tough case. Again, just go through the images as you describe it. I don't think you said this. These are fat saturated, T2 weighted or fluid sensitive images. Okay, here you can clearly see that the cortex of the patella on the inferior and even in the anterior segment is deficient. This is like a big either hemorrhage or edema, which we are seeing here. This is not the bone. The bone itself is absent. Okay, and when you're describing the patella with respect to translocation, always comment on the medial patellar retinaculum. Okay, it's thin now, there are partial tears. So there is diffuse fluid within the knee joint, and like you said, there's leveling, and these are globular flat structures, right? So that's why I showed you the T1. On T1, you can see that it is hyperintense, okay, and it is showing suppression on fat, so fat saturated images. Okay, and in fact, you can see these bubbles, rising through the effusion here. So just if you paid a little attention, plus this is your fat fluid level. Okay, so more commonly what we get is a clean layer of fat within the effusion in cases of lipohemoarthrosis, but this is also one of the presentations where you can have fat globules. Did you say osteochondromatosis? Yes, you said synovial osteochondromatosis. So loose bodies and synovial osteochondromatosis will not just hang on to the anterior surface in this manner, would they? Okay.
No.
But I asked you to show me the loose body because there was a loose body in this case. It's here.
Okay.
It's like hiding in the corner. Okay, this is the detached patellar fragment from here. Okay, so having a loose body in the joint space like this makes this an emergency. So it's not a simple case of translocation relocation, right? They need to go in and remove this loose body because it can get lodged in the joint in the future and cause more damage. All right. So the management becomes a bit complicated. So this was your last case. You have to be very careful to rule out pneumothorax and pneumoperitoneum. You can't just say, okay, there's no free air. So there is a subtle hint here, and if this was a rapid reporting case, you would have to report this as pneumoperitoneum. Let me just zoom in. All right, because this is not going with the rib shadow. Rib is going like this, and this is the diaphragm. but it's I think even more clear on the other side. This is the gastric bubble, and this is the pneumoperitoneum. And you either do a lateral decubitus film or you do a chest X-ray to further evaluate or clarify if there's pneumoperitoneum, especially if there's clean, highly suggestive clinical history. Okay. On the CT itself, you look at the way that the pneumoperitoneum is distributed to suggest what could be perforated. So over here you have these gas bubbles which are tracking through the liver lobes, and almost you can trace them to the duodenum here, and comment if there is any alteration in the appearance of the walls of the duodenum or the stomach, for that matter, some thickening or some adjacent fat stranding. So you can almost see the bubble, but honestly the surgeon was still not convinced that this is a perforated duo. They said their approach would be completely different if it's like a perforation from any other side. So we did have to, in fact, administer positive oral contrast in this patient. And so this is the second part of the duodenum, not the third. So you can see this it's going out exactly into the falciform ligament area, and then you have your air bubbles here. So when a CT is given to you immediately after an X-ray, you need to say, okay, these are the CT images of the same patient which confirm, what did you want to initially evaluate on the X-ray. So you need to stress that it confirms a pneumoperitoneum. It also shows a lot of free fluid, and I'm looking at the possible sites of the perforation. This is a young patient, unlikely to be a perforated like a large bowel mass. So I'm looking at the proximal or the upper GI, and I can see that there's thickening of the duodenum, there's fat stranding, and there's also air tracking very closely to these abnormal appearing duodenal areas. So I'm highly suspicious of a perforated duodenal ulcer in this case. Just looking at the rest of the scan, there's no evidence of diverticulosis or diverticulitis. Large bowel appears fine. I would urgently inform this findings back to the referring physician or the surgeon, and this patient would need probably operative management. Okay.
Okay.
So
I think I just got a novice and my terminology started going haywire to the Viva.
So that's the advantage of having a structure in your head. Even if you falter in one of the aspects of the structure, you can always come back with the next step, right? So if you're just widely speaking anything that comes to your mind, you'll get lost. And most of the time it is not the diagnosis part is difficult. Like I said, is the discussion part, and saying unnecessary things, saying wrong things, that will cost you your marks.
True. So is it okay to ask the patient or ask the examiner for history directly, or is it better to say that, okay, if the patient was presented with fever, then I would
No. So like I said, examiner wants to give you the clinical history, okay, but he wants to give it to you at a stage that he feels you have got some findings, at the stage where he feels that you can utilize the clinical history now. So once you reach the stage, and even if you just mention clinical history, you don't have to ask him anything else. He will give you the clinical history. Some examiners are nice. They might even give you the history at the start. But, a lot of examiners, they want you to earn the clinical history. That is what they say. And if you ask them directly clinical history at the start, they say clinical history is not available at the moment.
Right.
Okay. So the structure-wise, pertinent positives, negatives, then go for the clinical history before you mention the diagnosis.
Yes, right. All right. Thank you.
You're welcome. Dr. Swar, do we have the next hand?
Yeah, Dr. Wasif, Assalamu alaikum.
Hi, Danish. How are you?
I'm good, yeah.
Dr. Wasif, if I could just ask, in the duodenum perforation case, there's circumferential thickening of the duodenum. That's just secondary to the duodenitis, or was there an associated malignancy there as well?
No. It's just there's the inflammatory changes which have resulted from the ulceration and the perforation.
Thank you.
You're welcome. So, Danish, your first case.
So this is an AP projection of left humerus of an adult patient. I could appreciate, sorry, I think that's a skeletally mature patient because initially I thought it's I could appreciate the epiphysis separately. So there is some irregularity along the cortex of the proximal humeral diaphysis, and I can appreciate some sclerotic with some lucent areas involving the same region, which are representative of some aggressive matrix like moth-eaten appearance. In my routine practice, I would review the orthogonal view to further assess the area if we have that.
We don't have that, unfortunately.
All right. So considering skeletally mature patient with an aggressive aggressive matrix appearance alongside the periosteal reaction, I'll be considering an aggressive process involving the bones. The differentials in this age group would include primary osseous malignancy like primary bone sarcoma. The other differential would include a leukemia, and if the patient has fever or increased inflammatory markers, infection will also come in the differentials. So in my routine practice, I would correlate with the clinical history if it's available, and would
The patient does not have any raised inflammatory markers or fever, but he does have cough and some chest discomfort.
All right.
So we did do a chest X-ray for him.
Yeah. So the correlative chest X-ray of the same patient, the lungs are symmetrical and I cannot appreciate any consolidation within them. I'm looking at the hyla, which are symmetrical. There's mild widening of the superior mediastinum with the right paratracheal thickening as well. This may represent some mediastinal lymph nodes. Other than that, there is no, all right, there are no nodules and there's no pneumothorax. All right, so at this stage, since the child had some chest symptoms, but the chest X-ray does not, I'm unable to like pick any significant finding on the chest X-ray. So, but I could not leave the bony findings, which appears to be a bit aggressive ones. So in my routine practice, I would
Does the chest X-ray help you to narrow down your differential for the bony lesion? Do you have any positive, significant positives in the chest X-ray?
Other than the mediastinal, I think I could appreciate some right paraspinal retrocardiac.
That's fine. That's fine. So what about mediastinal lymphadenopathy? Does that help you in any way?
Yeah, mediastinal lymphadenopathy with the symptoms that could, favor an ongoing infectious etiology in the patient.
Infectious etiology. The patient, like I said, does not have any fever. So any other differential you have in your mind?
All right. So sorry. As I mentioned that the appearance on the bone is one of the differentials was leukemia and lymphoma, and since there is mediastinal lymphadenopathy, then this does favors lymphoma in this patient. So I would convey the findings to the referring and would suggest staging CT, chest, abdomen, and pelvis alongside an MRI for the assessment of the bony lesion.
Okay, I know the image is a bit weird for this case, but this patient is a 6-month-old baby whose mother felt a lump on the head.
All right, so it's a 6-month-old baby. This is probably a scanogram or an inverted radiograph of the skull, whereby I could appreciate a soft tissue swelling along the left parietal area. This can be further assessed with an ultrasound. I could not appreciate any osseous break in the provided image. In my routine practice, I would review any orthogonal view if available. And furthermore, this can be assessed with an ultrasound. In a 6-month-old child, if there is some history of fall, then this could be secondary to trauma. And if it's just an incidental thing, then I will be needing to evaluate it with an ultrasound if we have it.
Ultrasound was done, but what is your differential for this? So there's no history of trauma, and it's just some swelling with no tenderness that could be appreciated as far as the patient is concerned.
Yeah. So on this view, I could not appreciate any osseous lesion, but in this age group, if there is some osseous lesion like Langerhans histiocytosis, that can also give us soft tissue swelling. Other than that, in a patient with no history of trauma, we can also consider a non-accidental injury with this cephalohematoma. So that's why I would like to rule out if it's an hematoma or not on an ultrasound.
So how would cephalohematoma appear on ultrasound?
It will be just as in hematoma, it will be subcutaneous with internal hyperechogenic bands and strands with fluid intervening areas.
So on what layer of the scalp would you see the cephalohematoma?
All right.
Can you tell me the layers of the scalp?
I can try recalling them. So there is initial subcutaneous soft tissue whereby there is a fat, and then we have this. Okay, can I go from the deep ones? First, there is periosteum, and then there is subgaleal aponeurosis. So the cephalohematoma is basically lying beneath the aponeurosis and above the periosteum.
So where does subgaleal hematoma lie?
Okay. Okay, so I think I have gone the other way around. So cephalohematoma is lies superficial to the galeal aponeurosis, and the subgaleal hematoma lies beneath it.
So do you have a differential for this? Other than subgaleal hematoma, would you consider anything else?
Yeah, considering the image with this appearance, I've been also thinking for a cranial hemangioma, as I could see some osseous strands within it, that can also give similar appearance with overlying soft tissue swelling.
Okay. Next case. I'll just give you remote control.
All right. So these are the axial sections of CT abdomen with IV contrast. I'm scrolling through the images to just get an opinion, and we'll come back to it. So I'm scrolling craniocaudally. All right. So just for the sake of imaging, I will go through to the end of the image and we'll come back. All right. So now I'm scrolling back caudocranially. So I appreciated kidney in the ectopic location in the right hemipelvis. Scrolling cranially. Okay, so I could appreciate 2 native kidneys in their actual anatomical location, which suggests that there is a transplant kidney in the right iliac region. Both of the kidneys, native kidneys, demonstrates multiple cysts, which are replacing the normal renal parenchyma bilaterally. Furthermore, I could appreciate multiple variable size cystic areas involving the hepatic parenchyma, largest one in the right hepatic lobe. Yeah. So the overall findings do suggest conditions with association with associated findings. So bilateral renal cyst alongside hepatic cyst. All right. So one of the differentials would be polycystic kidney disease with multiple hepatic cysts. In my routine practice, I would inquire about the age of the patient. This does look like an autosomal dominant polycystic kidney disease with hepatic cysts and a renal transplant in the right hemipelvis. I would like to inquire the presenting complaint of the patient, since
Patient has a chronic medical condition, but currently is complaining of right hypochondrial pain.
all right, yeah, I could see some free fluid in the right hemiabdomen and try to ascertain the associative cause. So the gallbladder is distended with surrounding free fluid. One of the possibilities could be an acute cholecystitis. I'm looking for any calculus. In my routine practice, if there is any non-contrast image, I will review that to ascertain the cause. On the provided image, I could not appreciate any calculus. So one differential would be an acalculous cholecystitis, but that's usually seen with very sick patients or some patients on medications. Since there is renal transplant history, I could imagine the patient might be taking some immunosuppressants that would also call acalculous cystitis. I'm reviewing the vessels as well. So the vessels are patent. CBD is also dilated. I'm trying to ascertain. Okay. So I think
So
I'll.
no calculi was seen even on the non-contrast images. Anything else you can do for the patient? Do you have a diagnosis?
Since it's a renal transplant patient, I'm just focusing more. Okay. I'm also trying to look
They're
for.
not really worried about the renal transplant. The
Transplant,
patient's renal function is where we have given a contrast. So ignoring the renal transplant, what about the other findings? Can you sum them up?
I could also appreciate some bowel loops in the right hemiabdomen, which are thick walled. I don't know if they are due to because they are collapsed. But the prominent finding is the distended gallbladder with surrounding free fluid, for which I think correlation with the inflammatory markers can help. And sometimes you cannot see the calculus on the CT, so you can do an ultrasound to look for the non-dense calculi which are not dense.
All right. What about the background disease of the patient? Are you convinced it's autosomal dominant polycystic kidney disease?
Yeah, the imaging appearances do suggest autosomal dominant polycystic kidney disease. The other way around would be Carelli's disease with medullary sponge kidney, but then I would expect calcification within the kidneys that can also involve both organs. Sure.
Carelli's disease. So do you see that with dominant polycystic kidney disease?
No, that's what I was saying. That I mean, I was considering that as well, but that's not possible in this case.
Yeah. But is it not possible? In which condition is it seen?
I mean, usually with Carelli's, we do have medullary sponge kidney, like we have calcification of the renal medulla.
Any other condition?
All right.
That's fine.
Yeah.
So we'll go to the next case. So this is your next case.
All right. So this is a frontal projection chest radiograph of a skeletally mature patient. I could appreciate air fluid level in the right hemithorax. I'm looking for the underlying cause. So the irritated part of the right lung is unremarkable. The left lung is also within normal limits. The visualized bones are fine. So the only predominant abnormality on the right side is this homogeneously opacified area in the right middle and lower zone with a sort of a horizontal level at the top of it. This could represent, this could be either secondary to right-sided effusion. I cannot appreciate any pneumothorax or any fractures in the ribs. So still I would inquire if there's any history of any blunt trauma. So this could be hemothorax.
No history of blunt trauma.
All right.
The patient does have fever, which is long-standing.
So, I mean, this could be then if it's a long-standing fever, this could be loculated pleural effusion or empyema. So I think the patient would require further assessment with CT thorax with contrast to further evaluate the right-sided area as well as the effusion.
Okay.
So these are the axial images of the CT chest with IV contrast. I am scrolling craniocaudally. So I could appreciate there is, right. So there is an area of with internal fluid density as well as air lucencies in the right lower hemithorax. All right, and the pleural lining is thickened and also showing mild enhancement, which is suggestive of empyema. I am looking for the adjacent lung parenchyma to look for any communication, since it's not just a simple empyema. It has been complicated by air lucencies. So can I review the lung window, please? Yeah, thank you. So, I mean, the right lower lobe itself is compressed by this loculated right-sided pleural effusion. There are multiple internal lucencies. I'm thinking of two possibilities right now. One is either the empyema sac has communicated with any of the adjacent bronchi, in which case this will be like fistula, bronchial fistula. Yeah, bronchopleural fistula, sorry, yeah. And the other, since the patient has a long history of fever, so I'm also thinking of some necrotizing pneumonia with associated empyema on the right side. So among both conditions, it would be important to know the current status of the patient. The patient is acutely very sick. I'll be thinking more of the necrotizing pneumonia with empyema. And if it's a chronic condition with, if the patient is not very acutely sick, then I'll be more thinking of bronchopleural fistula in this case with communication with the empyema. So I'll be conveying the findings to the referee.
Fine. All right. So those were your cases.
All right.
So let's just start the discussion. Your first case, there's a permeative bony lesion, right?
Yeah.
So in your description, you need to mention 6 or 7 things for any bony lesion.
Yeah.
Okay.
Yeah.
It should come instantaneously. So there is a wide zone of transition. There is mild irregular periosteal reaction. I'm not sure. There might be some soft tissue component. There's no pathological fracture. And, you know, just what else? So the matrix, there's no definite matrix. It has a moth-eaten appearance. There is some cortical thinning here. So 6, 7 things should just come spontaneously. It could be benign, it could be malignant, doesn't matter. You just have to describe them. So this is an aggressive permeative bony lesion in a skeletally immature patient. My differentials would be 1, 2, 3. You don't need to think about them. Okay, it could be an osteosarcoma, Ewing sarcoma, leukemia bar lymphoma. Don't forget lymphoma. Okay. So here's the chest X-ray. If you had said lymphoma, I think you would have considered lymphadenopathy as a significant finding, but since you didn't consider lymphoma, you just ignored the lymphadenopathy. In addition, this patient also has an enlarged spleen. Okay, so here's the CT for correlation. So you can see there's diffuse mediastinal and hilar lymphadenopathy, and there's also some paravertebral abdominal retroaortic lymphadenopathy. Okay, so the spleen was enlarged. This patient went on to have a diagnosis of lymphoma. So I want to apologize about the images, but I showed it because it is an important case. And this is one of the cases that I was referring to when I said I was seeing for the first time in the exam. And I had to use my knowledge from internship, my memory, basically. So a cephalohematoma is outlined by the periosteum. It is limited with the periosteum. It does not cause suture lines. Okay. Subgaleal hematoma is between the galia epineurotica, and the periosteum. Okay. Finally, the last differential would be something between the skin itself and the galia, which is caput succinatum. Okay. Caput succinatum would have no problem traversing the suture lines, and it will be much more diffuse. Management is the same for all of them. Okay, which would be conservative. These things tend to resolve on their own. If the examiner asks you for management, you can be confident with that. We don't need to do anything else. So I'm going to show you the ultrasound images from Radiopedia.
All right.
Okay. So this is the gel, obviously. This is the skin. Okay. This is the subcutaneous fat or connective tissue, rather, which is beneath the skin. And then you have the thin hyperechoic layer, which is the galia, which is the scalp. Okay, beneath the scalp, again, you have adipose tissue, and then you have the periosteum. Okay, so in this case, the periosteum is elevated and there's fluid. Okay, so you have three hyperechoic layers, two almost, hypoechoic layers in the middle, separating the three hyperechoic layers. So this is cephalhematoma, subgaleal hematoma, caput succinatum.
All right.
Okay, the mnemonic for the layers of the scalp is scalp, skin, connective tissue, skin, connective tissue, and then you have the galia epineurotica, loose connective tissue, and then finally you have the periosteum.
Yeah.
So this case, you've seen cases of dominant polycystic kidney disease, right? You have diagnosed them, right?
Yeah.
How do the kidneys appear? Are they normal in size, small in size?
No, they are
in size?
usually enlarged. Yeah. And this is
so they're never the small. So what is the more likely diagnosis here? This is a recessive polycystic kidney disease. Okay, not dominant. So in recessive polycystic kidney disease, you have multiple small cysts, which does not cause enlargement of the kidney. Associated feature, which is more commonly known for recessive kidney disease, is liver fibrosis.
Fibrosis, yeah.
So it is conversely related. The higher the degree of cyst in the kidneys, the lower the fibrosis. And the higher the fibrosis, the lower the cyst. So generally, the patients that survive into adulthood will have a lower involvement of the liver. Okay, so we are not seeing any fibrotic changes per se in the liver, but there is liver enlargement, there's splenic enlargement, the portal vein is dilated. Okay, so Caroli's disease is associated with medullary sponge kidney, no doubt, but it is also associated with autosomal recessive polycystic kidney disease.
Yeah, true.
Yeah.
Yes. Yeah.
So this is Caroli's disease. And the patient has transplant kidney, which is incidental. We don't have anything to do with it. The patient presented with right hypochondrial pain. We suspected an obstructing calculus of the CVD or within the gallbladder. So we did an ultrasound for this case. There was a stone lodged in the neck of the GV, and there was probably some sludge or something, in the distal CVD, which was causing it to get dilated. There was no calculus in the CVD.
All right.
So the patient went on to have a cholecystectomy, and he was fine after that.
Great.
Your last case, so you said there is air fluid level, but
Yeah.
then you said there's no pneumothorax.
Yeah.
Okay, if you're not saying there's a cavitating lesion with an air fluid level, that means there's a pneumothorax which is causing the air fluid level,
Agreed.
right?
Yeah.
Yeah. So don't just say there's no pneumothorax. Be very careful with pneumothorax. Think about before when you think. This patient didn't have pneumothorax. So empyema is basically outside the pleural membrane, right?
Yeah.
So think of empyema as epidural hemorrhage. What is the shape of epidural hemorrhage?
It's crescented.
It is convex shape, because it is not allowed to expand. The hematoma or the collection is not allowed to expand. It is limited by the parietal meninges in that case and pleura in this case. So does this look like it is not being allowed to expand? The shape wise, it is perfectly round. It is like
Round,
expanding everywhere, and it has this thick wall. And at the interior aspect here, I think there's like some discontinuity in the wall. There might be some extension outside, but for the most part, this is limited or surrounded completely by lung. Okay, there's no pleural envelope which is limiting this this process. So this was a lung abscess. Okay, bronchopleural fistula is a good thought when you see air in loculated empyemas, but this is not to the degree that you would see in a bronchopleural fistula. Okay, this mottled appearance, this is of necrotizing air forming organisms. Okay, the previous X-ray was just for the patient. The patient just started out with consolidation. The antibiotic treatment was not proper. It progressed into this. And this is a CT for this patient. So involving the lower lobe, some part of the lower lobe is still spared, but most part it is necrose and it's turned into an abscess.
All right.
Okay.
Thank you very much, Dr. Wasif. Yeah.
Thank you. Dr. Sawahat, are you there?
Yes, I'm here.
I think we'll take a 5-minute break.
Sure.
Yeah, so I'll just share a link in the chat group for evaluation.
I did the one which I think I did. You can share it again.
Oh, okay. If you did, that's fine. So I would appreciate if everybody took like a couple of minutes just to fill in the evaluation form. Sure. And just if your experience didn't match up with what I said regarding how you should present the case. If you have given a recent exam, if the cases were not what I described, so I would like those comments as well. So we'll resume in 5 minutes.
Sure.
Okay. Okay. So yeah, this is your first case.
Frontal radiograph of a mature patient has been given to me. There is a well-defined opacity seen overlying the hilum on the left. I'm just trying to discern if this is overlying the hilum or can I see the hilum through it? I can see a few vessels which are traversing through this lesion, but all the vessels appear to converge into this. So this is likely a mass which is projected over the hilum. I can see the right heart border really well. So I'm thinking the vessels are not dilated. So medial to the mass, I can, however, see the normal lung markings. So my primary differential in this case would be a possible mass, intraparenchymal mass in this lesion, probably a carcinoma. I would like to further evaluate this with a CECT thorax.
Is there anything else that you find it's important to check on this X-ray?
Yes, there's an area of rib destruction which is seen associated with this lesion, which is just abutting this lesion. The left rib posteriorly is not well visualized, suggestive of infiltration.
I'll just give you the remote control if you can request it, please.
So I'm unable to see the left rib.
I think it's fine. It's fine. So you've introduced the film. You've given me some striking abnormalities. Okay, I want you to give me some pertinent negatives.
So I'm looking for any other lung lesions. I cannot see any. The cardiomediastinal contours are okay. There's no pleural effusion. The stomach bubble appears normal, and the visualized rest of the bones appear normal. So I would request for, there are no obvious surgical clips in situ. So
would you be looking for those?
I would, just to know if the patient has had a previous, okay. The left breast shadow is not well appreciated in the given radiograph. So I would request for any history for this patient that we may have.
The patient does have history of mastectomy.
So in a case of mastectomy, I would think of a possible lung metastasis, which has caused this finding. A possible differential could be a secondary, primary, could be a second malignancy in the same patient. However, the possibility of that is less likely.
So fine, I'm happy with your diagnosis. Do you have like a differential, or are you convinced about which? Is it a lung parenchymal lesion? Is it a mediastinal lesion? Is it a hilar lesion? Are you convinced about the location of the lesion?
It does have a broad base towards the mediastinum, but I can see a lung marking, a lung on the superomedial aspect. So primarily, I'm thinking this is an intraparenchymal lesion.
Okay. You can scroll through these images.
So I'm going to go to the area of abnormality. An incidental finding of an accessory azygous lobe was seen. So the abnormality seen on the X-ray is confirmed on CT. It does have a broad base towards the mediastinum, but it is an intraparenchymal lesion with heterogeneous enhancement.
So what's your final diagnosis? Stop scrolling.
My final diagnosis in this case is this could be a recurrence from the breast malignancy, and a secondary possibility could be a lung adenocarcinoma. So we would have to do an image-guided biopsy for this patient and referral to the MDT for further evaluation and management.
All right, just give me a second. So this is your next case. You can scroll.
I have been provided with sagittal T1 and T2 images of the spine. I am just scrolling through the images to look for any obvious abnormality. The bone marrow signal appears normal. I'm just looking at the cord to look for any obvious signal changes, but I cannot see any. The vertebral body heights are maintained. The intervertebral discs appear normal. Subcutaneous tissue appears normal. The descending aorta appears normal. There is a hyperintense area which is seen in the lower thoracic vertebrae at one level, which is hyper on both T1 and T2, probably just a benign hemangioma. I'm looking at the cord again to see if I've missed anything. But the cord signal appears okay. Could I request for clinical history for this patient?
Back pain.
So I'm looking at the vertebral column again, but the height appears okay. The C-spine is okay.
Can you tell me if you're happy with the vertebral column on T1?
So the marrow signal on T1 is hypointense compared to the, okay, the marrow signal is markedly hypointense as compared to the intervertebral discs, which is abnormal. And it's correspondingly low on T2 as well. So in such a case, I'm thinking of, there are a couple of differentials which fit into this. It could be in a male patient, a prostatic malignancy with diffuse sclerotic metastasis. We would have to include possibilities of multiple myeloma or other pathologies which involve the marrow, such as mastocytosis in this case. So we would go through the PACS folder to see if this is a diagnosed case of.
There's no previous imaging or clinical history for this patient. Any other differential? So your differential is correct, but you have not given me the diagnosis in this case. So I just want you to keep going with the list of differentials.
Metastasis, mastocytosis, lymphoma, leukemia, mastocytosis.
Fine, it is lymphoma. So, you know, these two, I mean, we'll come back to it. Okay. Yeah, your next case.
So I have been provided with MR coronal images of the abdomen on a fluid sensitive sequence. Just scrolling through the images once. The spleen is mildly enlarged, the kidneys appear normal. I'm just now assessing the bowel.
So is it a routine MRI abdomen study or is it something more specific?
It's a fluid sensitive sequence.
Okay, but the study itself, you said it's an MRI abdomen. Is it just routine MRI abdomen?
It's a markedly T2 hyperintense. So this could be, this is done for heavily fluid weighted sequence. So this is done.
No, that's fine. But why is there like so much fluid in the intestines? Why is it so much?
MR enterography.
Okay, fine, go on.
So this is usually done for inflammatory bowel disease follow-up. So I'm looking for signs of inflammatory bowel disease. I'm just following the large bowel. So the transverse colon is not very well dilated. I'm going to look at the small bowel now. There's no obvious dilatation which I can see. I'm looking for
which is the area which you would be most concerned about for a patient you know, who you've done MR enterography study for? Is there any segment of the bowel? Any segment of the bowel which you would be most concerned about?
I look at the IC junction.
Mm-hmm.
So I'm trying to look for the IC junction in this case. So I think the appendix is okay. The terminal ileum.
Have you found the cecum first of all?
Yes. I'm looking for the cecum. I'm tracing the descending bowel or the ascending colon. So this is the cecum.
Mm-hmm. So it's a low-lying cecum, right? Where would you expect the terminal ileum to be?
On the medial aspect. So the terminal ileum is here.
Mm-hmm. It's almost in the pelvis, isn't it?
It is. Trying to, but it's not abnormally contracted. There is no obvious.
So which loop are you looking at when you say it's not abnormally?
I was looking
That's
at
that's a cecum. That's a cecum.
abnormally
You need to look medial to it to see the terminal ileum.
Okay, so I'm just tracing the terminal ileum. So the IC junction is, there is thickening at the IC junction with obvious proximal holdup of contrast in this case. So
Where's the proximal segment? That is what my question is.
I
You're
think
saying there's no
proximal, this is the terminal ileum.
And where's the more proximal segment?
I can't trace. Okay, I think this is the more proximal segment here.
Keep tracing it.
Unable to exactly trace a proper communication between the two, but there is proximal holdup on dilatation of the loops within the pelvis in this region, with the circumferential bowel thickening, which is going over a long segment. So in this case, I'm thinking, to sum up my findings, the circumferential
negatives.
Okay, so I'm looking for any fistulous abnormal communication or a collection or a possible perforation, which I cannot see. In this case, I cannot appreciate the rest of the soft tissues here. So there's no phlegmon formation or see. There's no obvious phlegmon seen, but this area in the right iliac fossa, I'm not sure if this is communicating, this is a part of the bowel or this is an extraluminal connection in this case here. This could suggest a possible perforation in a case of Crohn's, because they do present with small collections.
What's a more simpler explanation rather than perforation?
A simpler, this could be an aneurysmal dilatation of the bowel loop itself.
No, for the fluid, for the extraluminal fluid in the abdomen or the pelvis, what do you first think of?
Free fluid.
Yeah.
So this could just be free fluid. So
free fluid loop. Yeah. Any other thing that you would check in a suspected case in your mind? I know you're thinking Crohn's. So any other things that you would like to tell me are pertinent negatives?
I would look at the sacroiliac joints to look for any sacroiliitis. I'm looking at the gallbladder to look for any obvious filling defects, which I cannot see. I'm looking for any withering of the intrahepatic bile ducts to suggest a possible associated primary sclerosing cholangitis, but could not see anything.
So just go through these images. Actually, I'll just scroll for you, and just. So these, what images are these?
These are contrast-enhanced, fat-saturated images on an axial MR. The area seen on the coronal, there is circumferential thickening along with fat attenuation seen within the bowel loop, which suggests fat, napkin fat sign, which is typical of chronic Crohn's. or chronic inflammation within the bowel. Any cause of chronic inflammation would cause fat attenuation within the bowel. So to put all my findings together, this is a case with chronic Crohn's disease. And if the patient is presented acutely, I would have to look for any ulceration or fistulation, which has caused the acute bout of pain.
Fine. Your next case, I think we'll start with this.
So I've been provided with contrast enhanced images of the thorax. There is a mediastinal lymphadenopathy seen. There are, okay. So I'm sorry, just to go back on top. This is an angiographic images. So I'm looking for any obvious filling defect within the pulmonary artery.
The vessels are fine.
Okay.
Any other abnormalities that you can see?
There is a soft tissue thickening seen in the left hilum with areas of hypodensity within. These are probably all suggestive of enlarged lymph nodes. There are also mediastinal enlarged lymph nodes. So could I see the lung window in this case? There are no features to suggest any mass consolidation, air trapping within the lung parenchyma. So just going back to the area of abnormality. There is a soft tissue mass with subtle surrounding ground glassing, which is seen within the left hilum, which showed heterogeneous post-contrast enhancement. So I'm looking for any bronchial cutoff, but this is encasing the bronchi rather than invading any of the bronchi. This is seen to encase the vascular structures rather than invade them. There is also reticulonodular thickening within the lung parenchyma in the associated area. So my inference from this case would be this could be a case of a primary lung cancer with the associated.
So you gave me the positives. I need two more things from you.
Okay.
I need some negatives.
Looking, okay, there is, I'm looking for, I should check the bones to look for any of these.
Very simple, very simple. There are no other lung lesions. There's no pneumothorax. There's no pleural effusion. Okay. So in summary, what are the two main findings that you're seeing here?
In summary, there's a left parahilar mass with associated mediastinal lymphadenopathy. There is also reticulonodular thickening.
No, that's fine. That's fine. So these are the two main findings. What would you do next in your answer?
Next, I would request for a history for this patient.
So this patient has history of treated pneumocystic Jirovecii pneumonia.
Treated pneumocystis Jirovecii pneumonia. So, okay. So
what does that tell you about the patient?
That tells me that the patient is immunocompromised. So this could, okay. Should I scroll through these images? Well,
no, that's fine. Just look at this mass and tell me if anything comes to your mind.
So this is a case, this is an immunocompromised patient. So I'm thinking that this could be a lymph nodal mass, which is proliferating along the vessels and causing.
What about the shape of this particular mass? Does the shape remind you of anything?
It's a flame shape. So this helps me come to a diagnosis of Kaposi sarcoma in this case.
Excellent. Yes. Well done. So that was your last case. We'll just start from the beginning. So I interrupted you because, if I tell you these things in the end, you'll again forget them and you'll, go back to your old ways. So, pertinent negatives are very important in coming to a diagnosis, but more importantly in showing the examiner that, you've considered a differential. So simple terminology, a well-defined opacity is seen projected over the left hilum. It has clean borders. There's no mediastinal lymphadenopathy. The left heart border is preserved. You can see the hilum overlay sign through the mass. Give the inference. That means this is not a hilar mass lesion. Okay, if it's a hilar mass lesion, then it would obscure the hilum overlay sign, and you're seeing the left heart border, so it's not an anterior mediastinal mass. Okay, complete the sentence. Just don't say that the left heart border is seen. And then looking at the other things, both lung fields, there are no other focal lesions. The ribs appear normal. In fact, you have to comment in particular about this rib. Okay, the overlying rib shows no erosions. It appears normal. The cardiometastasinal contour is normal. Just looking further, I can see that the left breast shadow is absent. So in a patient with a solitary solitary lung opacity with left mastectomy, I would think of metastasis in the first instance. I don't know if I would put another primary as a differential in this case. And you've seen cases of past history of breast cancer develop lung cancers?
Not always, but that's why I just put it low down on the list, because
Yeah, so unless the examiner is pushing you for a differential, I wouldn't bring that up. This is a clear-cut case of metastasis. I would just look at the examiner at this point. Probably the film will change, rather than say something controversial and get myself into hot waters. So this can be a tricky film if you have not seen it before, or even if you have seen it. The intervertebral disc signal intensity on T1 should always be lower than that of the adjacent vertebra. So you have fat in the vertebra, and you have fluid in the intervertebral disc. So fluid should be lower than fat. And in cases where the vertebral signal appears higher, then there's a diffuse abnormality. It can be proliferative. It can be bone marrow replacement or bone marrow conversion. So you have to give a couple of differentials for bone marrow replacement. And when you're thinking those differentials, you need to also, give some pertinent negatives. Because there's no paravertebral masses which could suggest extramedullary hematopoiesis. There's no lymphadenopathy that I can see in the given sections. There's no enlarged spleen. So if the patient is elderly, male patient, then the examiner will himself tell you, no, this is like a 35-year-old or 40-year-old female patient. Okay, so then that would be less likely to be prostate metastasis. It could still be a diffuse form of multiple myeloma if the patient is elderly, but this proved off to be CML. So I just wanted to hear you say differential for lymphoma. So actually, MR enterography has been shown in the exam, and it's an exam case. They didn't used to show it before, but it has been shown. So we all know we all should know at least. First of all, how to say that this is an MR enterography study. So there's the bowel is well prepared, there's fluid. I would advise you to look up how to prepare the bowel for an enterography study, by giving mannitol 1.5 liter 2 hours before the exam. The patient should be fasting. That can be asked. Techniques can be asked. So then almost immediately when you see an MR enterography study, go to the ileocecal junction. Okay, trace a large bowel like you did. Okay, no problem. But come down to the cecum and try to find the ileocecal junction. It's a bit tricky in this case, I'll admit, because it's a little low down in the pelvis. And you can see that there's this circumferential wall thickening of the terminal ileum, and the distalmost aspect of the ileocecal junction, there's almost fibrosis. Okay, there's fluid adjacent to it. It could just be inflammatory fluid. It could be like a focal collection. It doesn't have to be perforation. Perforation would lead to much bigger picture, or you can say localized perforation, I guess. So just prior to this inflamed segment, there is some focal dilatation. However, the rest of the bowel loops are not dilated. looking for any skip segments, and you can probably even appreciate there's some abnormality in the sigmoid colon. Okay, like you said, the segment of the transverse colon was also involved, looking for any fistulas, no fistulas. So just looking at the visualized sacroiliac joints, they appear normal, there are no gallstones. In this case, I would correlate with the patient's history. Patient presented with acute abdominal pain. So you can also request, even for me during the exam, I almost always forgot to ask for the contrast enhanced images, but you can request for those if you remember them. Otherwise, you can just summarize your findings, give a differential. So here you can see, a chronic fibrotic segment. This is how chronic inflamed segment would appear, small bowel. This is acute inflammation. So all of this is like acute inflammatory changes involving the terminal ileum. Okay, and when you're describing the contrast enhanced studies, say there's abnormal enhancement. I don't think you said that. This patient presented later on. This was routine MR angiography. This was an acute presentation. The CT was done. So a week later or so, he had this acute dilated small bowel loops, and we can correlate the MR findings what we saw. So now the dilatation has become more significant. This is the picture of small bowel intestinal obstruction. So you can be just shown this as an acute emergency, and this inflamed segment of the terminal. In fact, all cases, not just MR angiography, any case of small bowel dilatation, the first thing you should look for is the ileocecal junction. If the cecum and the ileocecal junction is normal, that means it is small bowel obstruction. If it is dilated, that means you're looking for a cause of large bowel obstruction. Okay, and there's some free fluid, which was probably also seen in the MRI. Yeah. So once again, you were running away with your findings, and you were just closing the case, reaching a diagnosis. So just describe the positive findings, pertinent negatives, no other lesions, no pneumothorax, no pleural effusion. So I would correlate with the history of the patient. Does the patient have any history of fever? Well, he did have fever a month back. He was treated for PJP pneumonia. So in that case, the patient has AIDS. You're thinking of AIDS-related diseases, and this appearance of flame-shaped soft tissue density in the hilar region. Perfectly done. This was Kaposi sarcoma. Am I audible?
Thank you. Yes, no, I was just taking all the information.
Okay. Sorry, I should have waited for your feedback there. So it's getting a little late for everyone, so I'm just trying to push on.
Thank you so much. No, great cases.
You're welcome. You're welcome. So we have, do we have candidate 5?
Yes, candidate 5.
Hello. Yeah. Hello, Dr. Wasif. Yeah, I'm there.
Hi. So this is your first case.
Okay. So I have been provided with a frontal radiograph of a skeletally mature patient. I can see that there is abnormality predominantly in the left side, left hemithorax involving the lung. There is an area of airspace opacification in the left upper lung field. And also I can see there is a cavity which is thick walled within the area of opacification. The lung volume is there is no significant loss of lung volume. Other than that, I'm looking for any other cavitating lesions. I don't see any other cavitating lesions. The cardiothoracic ratio is okay. There is no pleural effusion. And looking at the bones, the distal end of clavicles appears slightly osteopenic. However, I will correlate with the history. Other than that, the bones appear normal. Bilateral breast shadows are normal. And also I can see some retrocardiac opacities. So this could be also a part of the infection process which is going on in the left lung. In my routine practice, I will look at why the patient has presented.
Patient has history of fever and cough.
Okay. So in a patient with a history of cough, with these kind of findings, I will first think of some infective process going on with cavitation, and I will convey my findings to the clinical team.
What would be your differential for an infective agent in this case?
So most likely the cavitation is by Staph aureus. Other streptococcus can also cause sometimes cavitating pneumonia. Other are pneumococcus and Klebsiella. Mostly they will present with bulging fissures, which I'm not seeing in these cases. So the patient will be treated with antibiotics by the clinical team. And if the findings have not resolved even after 6 weeks, then a repeat X-ray will be done. And we will take it
So a
from
repeat follow-up CT was done for this case. Can you request the remote control?
How to do that?
Candidate 5.
I'm not sure how to do that.
Just give me 1 second. I'll just do it from my end.
Okay.
Okay, you should have it now.
Okay. Okay. So I have been provided with the axial sections of the thorax of the same patient who has been treated before.
Would you prefer lung window?
Yes.
Just 1 second. Let me just do it. Yeah. Okay.
Okay. So so the patient has been treated, and I have been provided. Okay. So I have been provided with a lung window, and I'm just scrolling through the images once to see what's happening. Okay, so there I couldn't see, there is trace of left-sided pleural effusion, and I saw that in the left there are abnormalities in both sides of the lung. So there are multiple pre-in-bud opacities, and also on the left side there is a large cavity which is thick-walled. And there are some adjacent pre-in-bud opacities. Similar opacities are also seen on the right side of the lung in the bronchocentric pattern. In an elderly patient, my first possibility was of pneumonia, but because the patient has already been treated, I'm also thinking if...
This patient was given antibiotics for a week and it didn't respond, so the CT was done.
Okay. So in my routine practice, I also look at mediastinal window to look for the nodes, because this, this has not resolved. So I will also think of some cavitating malignancy in an elderly patient. And
this patient is 40 years old.
Yeah, so I will think of a cavitating malignancy, which in
40.
This.
Okay.
Yeah, because or it could be some atypical infection which has not resolved because of the routine antibiotics given.
Mm-hmm.
So,
like what do you think?
Like fungal infection could be, or like tubercular infections. Maybe they have treated with routine antibiotics.
So this is the next case.
Okay. So these. Okay, so these are the axial sections in or contrast enhanced images of the thorax of an elderly patient. I'm just scrolling through the images to see what's happening. So when I'm coming down, so I can, okay, so this is abdomen actually. So it's just not scrolling on my page, so I'm sorry about that. So I have seen a large lesion is there in the liver. I will just see the rest of the images and then I'll come back to it.
That's fine. You can concentrate on the liver.
Okay. So I can see that there is a large, this is a portovenous space. And in the liver, there is a large solitary lesion in the right lobe of the liver, which is, sorry, the scrolling is, should I use the key?
Yeah, right and left arrow keys are fine. They work for most people. Right and left. Yeah.
Yeah. Okay. So there is a large solitary lesion in the right lobe of the liver. The background liver is not appearing cirrhotic. There is no splenomegaly. A large solitary lesion in the right lobe of the liver can have wide differentials. If the patient has presented with fever, raised inflammatory markers, it could represent a solitary abscess as well. if the patient, I mean, in my routine practice, I usually correlate with the history. And I also look at the entire set of images in the triple phase to look for the enhancement pattern of
The
the lesion.
patient just has some abdominal pain and tenderness. It's been getting more severe since the past few days.
Okay. So do I have like other?
No, this is about it.
So I will
Yeah.
just scan through the images if there was an abscess which might have ruptured and it's now causing patient abdominal pain. In the abdomen, I can see that in this area there is some fat stranding also. So I'm also thinking of some infective process which is going on.
Other than abscess, what is your differential? Yes.
So other than abscess, it could be like primary lesions of the liver, like if the patient is a female patient and if there was a patient is taking some contraceptives and there was a large adenoma which has increased in size. And also I can see some intra-lesional hyperdensity.
Just 1 second, I'll give you the plane, no problem. Take the plane.
So on the plain film also, I can see that within the lesion, there are some areas of hyperdense signals that could represent some hemorrhage. If the patient is female, and patient is, I will just go see if the patient is taking some contraceptives. This could be a large hepatic adenoma, which has now happened.
So you asked about the clinical history. The patient is not a female, it's a male patient who has recently emigrated from a North African country.
Okay, so patient has emigrated from North African country.
Or Indian subcontinent.
Okay, so I'm thinking of hydrated cysts are usually like calcified peripherally, and if it is some abscess like amoebic abscess, they can also be solitary or some like pyogenic abscess. So I'm thinking more in terms of infective pathology in this patient.
If you had to pick one, which would it be?
I will pick abscess rather than hydrated, and because it's solitary, I will pick amoebic abscess as first differential in this. So the patient needs, if it's an abscess, even an ultrasound can help to further see about the internal contents. And if
next case.
So these are the axial sections of the abdomen in an elderly patient. I'm scrolling through the images first. So I can see there is a lot of fat stranding, free fluid, intra-abdominal free fluid. The right kidney appears atrophic. Left kidney, there is a large, I think, cyst.
Did I tell you in the beginning of the session that no examiner wants to hear about the cyst?
Yeah.
I was quite specific, right?
No.
So just scroll through, just see if there is something which, just scroll through the image, just see if there is something more concerning.
So I'm
you don't have to talk while scrolling. Just scroll.
So I will just take a while to scroll through the images and like understand what's happening. So I can see there is okay. So when I came to the area of the pelvis, I can see that there are a lot of air fluid, like intraperitoneal air foci within the abdomen. And most of them are within the area of the pelvis. I don't know if the patient had any trauma. I'm just looking at the bones also.
No history of trauma.
Okay, so no history of trauma. I can see that there is a catheter in the bladder. Yes, and there is a lot of intra-abdominal free fluid and stranding, and there is I'm just looking at the bladder. If the sorry, I'm not.
No, take your time. You don't have to apologize. Take your time. Take
no, the scrolling. I'm not doing the scrolling properly.
No, scrolling is perfect. Scrolling is never blame the technical errors. It's never the technical thing. Everything is projecting while scrolling is perfect. You're just nervous. Take your time.
So I'm also looking at the sigmoid colon. So if there is, yeah, I'm just tracing the sigmoid colon.
What were you tracing before the sigmoid colon?
Previously, I was looking at the urinary bladder. I was looking for, I mean, I was seeing that there was.
Is it fine?
No, no, it's so there. Yeah, so this is the catheter, and this is the Foley's bulb, and then I'm like losing it. I'm not. So I'm just thinking if there is like rupture of the bladder wall and the air, there is like traumatic like iatrogenic rupture of the bladder wall, and then there is air and the surrounding fluid is because of the bladder, because the position of the urinary catheter is not in the pelvis, it's like very higher up. So I'm not happy with that.
So anything you can do for this patient?
So I will actually, this is a surgical emergency if it has ruptured the bladder. So I would urgently convey my findings to the surgical team on call. I will tell them.
What would you,
Yeah,
you would tell them there's definitely a bladder rupture or suspected bladder rupture?
I will tell them there is a suspected bladder rupture because a lot has been going on in the
Can you do anything better than that? Can you tell them a definite diagnosis?
Yeah, so I will do contrast. I mean, I can give a retrograde contrast through the that catheter, and I will look for the area.
Yep. Can you go through these images?
Yeah, just a minute. Yeah. So all the contrast has leaked. So this is the bulb. And here the rupture, there is a rupture of the urinary bladder.
This patient had actually presented with a suspected UV mass. What do you think?
So the patient, yeah, here I can see a large soft tissue density mass also. And the patient, so
where's the urinary bladder? Where's the urinary bladder?
Because so here is a Foley's bulb. And I
Where's
can
the uterus? Where's the uterus?
Uterus. Just 1 minute. I think this part which is having the fluid, this could be the uterus. This area, or this could be, this is bowel.
Okay, that's fine. You got the diagnosis. Basically, the patient had. Let me see first if I have any more cases for you.
Okay.
Yes, there's one more case. So, okay, next case.
So this is the, okay, so this is the axial sections of the thorax CT of a adult patient, female patient. And I'm just scrolling through the images once. Okay. I'm going back to the lung window. So the abnormality is in bilateral lungs. So there are multiple areas of airspace opacifications in predominantly perihilar distribution. And some of them are also showing green bud pattern.
Just give me 1 second.
Yeah.
Okay.
Okay. So, yeah. So some of them are giving like tree and bud pattern, or some are like coalescing together to form areas of consolidation. So, sorry about that.
No issues.
Yeah, so multiple areas of airspace opacification in bilateral lung fields with tree and bud opacities. I'm thinking of infective. In my routine window, I actually first look at the mediastinal window to look at the nodes, if there are any enlarged mediastinal nodes. Yeah, so on this, there are paratracheal, subcarinal. Yeah, so there are multiple, like they are not grossly enlarged, but there are some nodes.
So are you happy with the tree in bud appearance? Are you confident that it's just tree in bud, or do you have like a differential in mind?
Okay. So actually, these opacities are showing tree bird pattern. And also, I think that some of the in some areas, I can also see like along the fissures, there looks like perilymphatic fissures are like showing. I'm just scrolling the wrong way. Sorry. Okay, yeah. So these areas, they're also showing some nodular kind of pattern, these the fissures. So in view of the like perilymphatic nodular pattern and areas of airspace opacification with also hilar lymphadenopathy, I would also think of sarcoidosis as one of the possibility. And I will look at the previous images. If it is a new finding, I will ask the clinical team to also do a ACE levels and serum calcium levels. And for the definitive diagnosis, like bronchoscopy assisted, like biopsy from one of the nodes can also be done. And the case can be discussed in the lung MDT for further management of this patient.
Fine. Your diagnosis was correct, but I think you will struggle to get a 6 in this case because you didn't describe all the findings, you didn't give any pertinent negatives, you didn't consider the clinical history. So we'll come back to it. Yeah, no, that's fine. That's fine. It's just we have to learn from our mistakes. So I'm being frank and open with you.
Yeah.
So it's not just about getting the diagnosis, seeing the management. You know, they'll be happy to just put the next case on. Okay, if you want to close it, but they won't give you the full marks for it. Okay, so this is the first case that you saw. So there's a cavitating lung lesion, this thick wall, but additionally there's this area of consolidation or ground glassing. So you can see air bronchograms. There's no loss of lung volume. Okay, no other lung lesions, no pneumothorax. So you were perfect on that. On the CT, characteristically, you're seeing these tree and bud opacities, cavitating process, which is involving both apical regions. No significant lymphadenopathy. The patient is not responding to antibiotics. I would put TB as my first differential here. Patient is young, so the differential of cavitating malignancy would be less likely.
Mm-hmm.
So this case, this is a spotter. This is a spotter for hydrated. Okay, these are enhancing septa in a cystic lesion, which is thin walled. There are no air foci to suggest an abscess. The patient did not have raised inflammatory markers or fever. So other than that, you can think along the lines of hydrated and say that I'm looking for daughter cyst or calcifications, which is not there, but overall appearance are quite characteristic for hydrated.
Sorry, Dr. Wasif, can you just tell like what we have to, because I was looking for daughter cyst and calcification. So like how we have
to.
So
these are floating membranes, this is called water lily sign.
Okay.
So in chronic cases or in various other cases, you might see daughter cyst. So these are like variable appearances.
Mm-hmm.
So you can't stick to just like one feature which might be pathognomic. I mean, but if you don't see it, it doesn't necessarily. But once fever is not there, abscess is difficult, and abscess without air foci is again difficult. So, which was the next case? Yeah. So this case again, this is like old habits die hard. You just have to finish scrolling. There's a plain CT study of the abdomen of an elderly patient. And these are the axial sections. I'm just scrolling through it. Very slow, very steady. There's no hurry. You take 3 or 4 seconds. So the striking abnormalities of this patient are in the pelvis. And, you can see this air foci. Again, in your hurriness, you tend to say wrong things. These air foci are not intraperitoneal. They are all extraperitoneal. So there's no like intraperitoneal extension of the fluid or the air foci. So there's an extraperitoneal rupture of the bladder. This is an atrophic uterus. The Foley's is outside the bladder. This patient had presented with suspected bladder mass, and they did a cystoscopy and a biopsy for this patient, after which, basically iatrogenic complication of extraperitoneal bladder rupture. So one of the bowel loops over here is surrounded by the contrast, but it's not necessarily extending into. So I think this bowel loop.
So, Dr. Wasif, if
Yeah.
we're seeing the contrast, like because I saw like between the bowels also. So
That's what I'm trying to tell you. This is not between the bowel loops. It's still extraperitoneal.
okay.
So the sigmoid is here. It's just indenting over here. I mean, this is still, not. This is the intraperitoneal location. So this is like the antiperitoneal side of the bowel. Okay. So this is all. It doesn't go into the. If it's intraperitoneal, it doesn't. I mean, it could be intra and extra, but less likely. So inguinal regions, the pelvic region is all extraperitoneal. So yeah, there is like bilateral perihilar opacities, almost in a bat wing configuration, and there are multiple nodules. Don't just rush to say tree invert appearance. So the nodules are again, extending along the fissures. Are they subpleural or not? Some of them are subpleural, and some of them are coalescing to form like other masses. So in sarcoidosis, you have something called the galaxy sign, where you have like a mid-sized nodule, which is surrounded by the smaller nodules. So there is galaxy sign. Pertinent negative would be there's no calcified lymph nodes, axial calcifications. There's no like consolidating masses. You can ask, I mean, normally in the exam, they won't give you the coronal, but the coronal is here. So yes, this patient was actually misdiagnosed as an infective pathology 3 or 4 times in different hospitals. And finally, he came to our hospital, and it was suggested for sarcoidosis, and later biopsy was done, which proved to be sarcoidosis.
Okay. Nice.
Okay. So I think that concludes our session. Dr. Sabahat is still awake.
Yes, why not?
Yeah,
Well,
this is one of the longest sessions that we have had.
No,
You're welcome.
But it was an extremely good session, and especially the part you did in the beginning. It gives a very good perspective of how the approach should be to the exams. I'm not going to take much time, but just I want, just to see Dr. Wasif. I think that his camera was on. So have empathy for the examiner. When we go for our exams, it will help us. You see, being an examiner is not easy. They're not our friends, but you have to be in their shoes and understand that they're going to take the examination the whole day. So have some empathy when they give you the hint, take it. Do not irritate the examiner by not taking the hint. And Dr. Wasif, excellent session, excellent cases. I appreciate all the efforts you've put in through our preps. And it's always to have people back. Thank you so much. Thank you all the volunteers who made this 2-month duration of prep possible. It could not have been possible without them. All those 2-hour sessions which everybody volunteered for, it helped a lot. In their on-calls, in their workload, with their family commitments, everything helped, inshallah. And just to keep myself short, go ahead, doctor.
Best of luck to everyone, inshallah. I think everyone will do great. So we'll conclude here. And I'm getting a few. I'm getting a few questions in the chat. Actually, I'd be happy to reply to them in the group. So I think we're a bit beyond our time. So just post them in the group. Okay.
Okay. Thank you very much, Dr. Wasif.
Have a good night, everyone.
Session. Bye.